Welcome back, my dears. Welcome back. Another part we'll talk about right now in curriculum. And here we will talk about something we call personhood, promoting an interaction worker in helping the dementia cases varied based on the stage. But in general, all the stages need the following: validate. Validate means supporting a person's emotions and feelings. So as the personal support worker is having a long contact with the patient. In that case, he is the one who's very closer, is the closest one to the patient, sometimes more than the family members themselves. In that case, he should give a support and listen to the emotions and the feelings and to the whatever the patient say. Collaborate, working together to enhance a person's abilities, encouraging control and choice. We said this before, the rights of the patient, the autonomy. Autonomy means the rights of choice. So give the patient, the dementia patient, the right of a choice. Facilitate, accommodating a person's disabilities to enable task completion. Play and celebrate, encouraging spontaneity and self-expression, joyfulness and celebration just for fun. Relax, helping a person relax and feel comfortable without making any intellectual demand. So these are the points which you should do while you are giving care to a patient. We have treats and personhoods. We call it treats to personhood. There we have chemical restraints, like the medications. As example, the chemical restraints or the medication used to control behavior or restrict freedom of movement, not treat a medical condition. So the chemical restraints is like taking medication or whatever just to control the behavior. We have also physical restraints, equipments or devices that restrict freedom of movement to access the one's body or environment. We see it usually in the hospitals, the restraints and how to set the restraints for a patient who's not preferably to move and so on. What about the malignant interaction? The malignant interaction, including the following: infantilize, treating a person like a baby or a child; outpace, providing choices or tasks at pace too fast for a person to follow; impose, forcing a person to do something; ignore, carrying on conversation; label, describing a person by their behavior or diagnosis; and intimidate, including fear in a person through threats of physical power. Those are the points, and I guess I just want you to know it before we go to module 2, to move into module 2. In module 2, I just want to tell you that even though a person with dementia may look physically well, changes in the brain impact their experience and interaction with the worlds around them. So even though he looks like normal, but there are changes in brains which we talk about, like anger, mood, and when the sun is downing, sundowning as well, change in the behavior, social isolation. All these are changes, loss of hobbies. All these are things changed in the case on the dementia patient, and you have to be aware of it. We'll move now into the 3Ds of a dementia, or the 3D of dementia. And this is very important part. I just want you to know it. The 3D of dementia. What are the 3D of dementia? And what shall a healthcare provider do in all the cases? We talked about the dementia before. We said we have 3 stages for the dementia. We have the early and the moderate, moderate stage, then the severe stage. We have the dementia here, the 3D. The first one of them is the dementia. It's a progressive cognitive disorder. Progressive means no way down, no back to track. It means situation will get worse and worse. This is for the progressive. Cognitive means brain work on the brain. Disorder means dysfunction. So a dysfunction in the brain, and this is progressive, means it does not go back to track and no any chance or opportunity to heal up or to recover. No way to recover. Everything like it's going down is getting worse. It's getting worse. So you can say progressive, getting worse. The delirium. Delirium, a sudden onset, urgent situation. And this is urgent situation. Depression is a treatable mental illness. So those are the three things with the D or the 3DS of dementia. Dementia, delirium, depression. طب how can make how are we can differentiate between them? How can we differentiate between them? For the dementia, it's a gradual cognitive decline, like we said before. Delirium, abrupt onset of decline, and depression, abrupt onset of decline. These are the three things. Dementia, normal alertness until end stage. So it's going, the delirium is disturbance on consciousness, and the depression is reversible. The word reversible means can be healed, or once a person is treated from the depression, he can get back to normal. This is the meaning of reversible. But you see that the dementia is irreversible. The dementia is irreversible, while depression is reversible. Dementia is irreversible. Look at that. Dementia means it's a progressive, means it doesn't, it get worse. Irreversible means it will get worse. It's going from worse to worse. But delirium is reversible, and depression is impairment in social, occupational areas of function. Yes, like as example, I take away from the people, I get away from the people in social isolation and so on. This is depression, and depression is having prescriptions right now and can be treated. Yeah. Okay. Impairment, the dementia, impairment in social, like you see here in social and occupational areas of functioning. Here, delirium, change on cognition that cannot be accounted for by a pre-existing medical conditions. The depression, diminished interest and pleasure in all activities. You feel like you hate the life and you hate everything in the depression. Depression, dementia is normal attention span until late stages. Like we said, dementia is progressive, means is getting from worse into worse, more and more, till the end of the death of the patient. Delirium is often occurs at night. It occurs at nights, usually it occurs at nights. Delirium is reduced levels of consciousness, but reduced level of consciousness means I'm not very aware of what's surrounding me. But wait. It is reversible. Reversible means that it can be treated, it can be healed, it can be recovered. Person can get back to normal. In the delirium and the depression, person can get back to normal, but dementia, no. A person will never get back to normal. So these are the differences between the three situations. Like here, these are the differences. I will go just to make a zoom more on the difference between the delirium and the dementia. I will make a difference also, another difference between both of them. Delirium begins suddenly and develop quickly. This is the delirium. Dementia begin gradually and progress. So this is another difference. Here, start suddenly and develop quickly. This is the delirium, but dementia begins gradually and progress. Delirium define the starting point. But here, we are not certain in the dementia, uncertain starting point. We are not quite sure when did it start. In the dementia, we are not quite sure when did it start. The delirium is temporary and reversible, like we said before. It's temporary for a matter of time, like I said as example, temporary unconsciousness. This is the delirium. Temporary unconsciousness. But the dementia, like what we said, is permanent and worsens. It's getting worse, 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 till at the end, the late stages where, and after this, the death or the pass away of the patient. Delirium, difficulty paying attention in the delirium, but in the dementia, difficulty remembering. Look at this here. It's a matter of consciousness. In the delirium, it's a matter, and when we said also, just let me remind you that it's reversible. Difficulty paying attention, but in the dementia, difficulty remembering, like what you see in front of you here. Difficulty remembering. I can't remember. And it has 3 stages here. And some books divide it into 7 stages, like what we saw. Early stage, middle stage, and the late stage. This is for the dementia. The delirium causes slowed and slurred speech. So it causes slurred and speech and very slow speech as well. Here, dementia causes forgetfulness of words. The words, I forget the words. I forget everything here in the dementia. So this is another difference between delirium and dementia. I just want to go now for a small video, and I'll put the link also as well between and delirium. Difference between dementia and delirium. And let's see what we'll get here. Now I'll put the links also as well for these videos right now in front of you. Here we just want a small one, like around here. Differences between delirium and dementia. This is a very good one and very small and very short as well. And this.
Okay, so in this video, we're going to be talking about the differences between dementia and delirium. First of all, delirium is defined as an acutely disturbed state of mind, characterized by restlessness, illusions, and incoherence. Bear in mind, though, that this can be associated with hyperactivity as well as hypoactivity. So what is the difference between delirium and dementia? The mnemonic we're going to use is OCD CAMPS. The O stands for the onset, which is typically rapid in delirium, within hours to days, while in dementia it's over months and years. C is for the course. Delirium is often fluctuating, meaning the patient may be quite settled at some points and more agitated in others. Typically, there's the sundowning phenomenon, where patients with delirium become more agitated towards the evening. In hypoactive delirium, this is harder to appreciate, however. Dementia, on the other hand, gets progressively worse. Next, we have D for duration, which in delirium is mostly days to weeks and is reversible, although it can last months in causes such as liver failure. In dementia, the duration is again much longer, months or years, and in this case is irreversible. The second C is for consciousness, which is usually altered in delirium, while in dementia they can be clear, although of course this can be affected greatly in dementia too. A is for attention, which again can be altered in both dementia and delirium, but in delirium there is a significant impairment typically present, while in dementia the attention may be somewhat normal, given that overall dementia is mostly associated to memory loss, while delirium heavily features a lack of concentration and inattention. M is for memory. In delirium, the immediate recall is usually impaired, while longer-term memory may be quite good. In dementia, however, the immediate recall is often normal. P is for psychomotor changes, which, as we mentioned in delirium, can be hyperactive or hypoactive, whereas in dementia, psychomotor disturbances are not usually present. Finally, we have the S for sleep-wake cycle, which again can be altered in both, but is often significantly different in delirium. Often a complete reversal of the sleep-wake cycle is present.
I put for you guys the link of this video. It's here. I'll put it here right now, here for you for getting to get it for future use. Here it is, new slides, and here the link of this video. So you can get it also whenever you wish to come to it. Also, still I'm talking about the disorientation and delirium and dementia, and we talk about disorientation also is a symptom of an underlying medical condition, such as depression. So the disorder here is the talk about the depression, because we said also we have the difference between three things: depression. And depression, what's the main thing of the depression? That it's reversible, means if you take medications and avoid the reasons for the depression, the patient will get cured and healed back. One of the aspects of the depression is impairment in social, occupational areas of functioning, and diminished interest and pleasure, and inability to think and concentrate. This is the depression. So we'll go back now here to disorder like medical conditions such as depression, electrolyte imbalances here as well, electrolyte imbalances, or even brain tumor. So disorientation is a temporary, something temporary. Disorientation also, like we see here, disorientation here, delirium and dementia are not a normal part of aging. So those three things, we just want to say that the disorientation and delirium and dementia is not a normal part of aging. It means it might come to a person who's young, and it doesn't mean that he's old person or aged person that he will get disorientation or delirium or dementia. It doesn't mean like this. It doesn't mean when a person get old that he will get any of these three. It is not a life an age sickness. So again, disorientation, delirium, and dementia are not, take care, are not a normal part of aging. Means it doesn't mean that when I come aged person that I will catch disorientation or delirium or dementia. No. Symptoms of disorientation. The symptoms of disorientation include anxiety, tremors, hallucination, delusions, angry, restless, depressed, or irritable. These are the things which in the disorientation. For the delirium, like we talked before, and I'm saying again more points about the delirium: attention disturbance, you're not very focusing, incoherent speech, slowly of speech, disorientation to time or place, change in sensation and perception, signs of illusion and hallucination, changes in sensation and perception, which increase the disorientation. Like what I showed you right now, that both of them, disorientation and delirium, are reversible. Reversible means can be treated, but it takes some time, and it will take some time to work on it. What about the minimizing the here, like what you see in front of you? I just want to enlarge the slide so that everybody can see it properly, and just increase it here inside. Minimizing the disorientation, like what we do for minimizing the orientation. Let me go here and put also on get the red pen, the red marker, so we can see here. Minimizing the disorientation here, getting regular hours of sleep. So if I want to reduce the disorientation, including also the depression, so what I will do is getting regular hours of sleep, eating a balanced diet that has plenty of vitamins and minerals, not drinking alcohol in excess, keeping careful control of blood sugar if diabetes is presented, and not smoking as well. So these things will help to reduce the disorientation. We said before, the disorientation is including also the depression, and we said that these are reversible. For the treatment in patients, we have blood work, including blood and alcohol levels. This is for the for the delirium, So we have blood work and MRI scanning for the brain. Also the chest x-ray is helping as well. And so those are things which we use for the delirium. Okay. One more words about the relationship between delirium and dementia. To talk still, we are talking about the relationship between the delirium and dementia. We said why we are doing this now, because we have in our course the 3Ds of dementia, which I talk about, the 3Ds of dementia: dementia, delirium, and depression. The three things of dementia. That's why we said, and we talk about them. We said here in this slide. In this slide, we said the dementia and delirium and depression. And the most important thing of them, these are disorders. Like this example, the delirium and depression, they looks like there are mental disorder, and they are reversible. But dementia is not reversible, like we said before. And beside all what I said also for differences between delirium and dementia, delirium begins suddenly and develops quickly, but dementia begins gradually and progress. Delirium defines a starting point, but dementia uncertain starting point. Delirium temporary and reversible. Once it's treated by drugs and by avoiding the reasons and taking the precautions, then person will get back into normal in the delirium. But this never happened in the dementia because it's a progressive and getting worse and worse. And the last thing, the difficulty paying attention in the delirium and slow of speech and so on. And usually in the night and when the sun downing, it's a sundowning symptom sickness, but the dementia, difficulty remembering, like we said before. And I showed you a video and I said now, disorientation also, like I said, here is including the depression. So it's different between the depression and the, okay. Shall we go for the causes of disorientation right now? Causes of disorientation. What are the causes of the disorientation? Usually alcohol intoxication, the increased amount of alcohol, low blood sugar, heart trauma, and heart and head injury concussion, fluids and electrolytes imbalances, neutral or deficiencies as well. Nutritional deficiencies, particularly niacin, thiamine, and so on. This also, or lack of vitamin C or vitamin B12, or has a fever, or sudden drop in body temperature, which is called hypothermia. We call it hypothermia. That is a sudden drop in body's temperature. It's called hypothermia, like you see here. Sudden drop in body's temperature, hypothermia. So these are the reasons. Low levels of oxygen as well here. Chronic lungs disorder, medications, infectious, brain tumor, certain psychological illnesses, especially in older ages, and so on. These are the things which are causes of disorientation. Take care. The depression is a type of disorientation. Now, when we go for causes of delirium, the causes of delirium needs to be determined and the delirium needs to be treated. Delirium should always be treated as an emergency. Please don't forget this. It's an emergency case and has to be treated as emergency. This is the second difference also for between the delirium, the causes of the delirium and the causes of the disorder, including the depression as well. Disorder, including depression. Okay, here we go. Now, let us reduce the size of this. And we set the delirium and the depression back. And these are the disorientation and the causes of disorientation, which I said here, and how to minimize the disorientation by eating balanced. How to minimize the disorientation by eating balanced foods, And the vitamins, care about the vitamins, not drinking alcohols, keep careful control of blood sugar, also, and not smoking. This is to reduce the disorientation. And the treatment also for the delirium must make a blood work and the test of blood and alcohols and MRI scanning for whenever it is possible. Now, let us go for the difference between the delirium and dementia. And this will be the last part here today. Our part today is 3D of dementia, delirium and depression and dementia. Delirium is a risk factor. Okay. For future dementia. Because this delirium can lead into dementia in the future. So delirium, if it is not treated, though it's reversible, but if it is not treated, that it can lead to future dementia. But baseline dementia is also a risk factor for delirium incidence. So also the dementia is a factor for the delirium. The cognitive impairment, cognitive means the brain or intellectuals or thinking or the parts which is working mental, the mental part of a human. Cognitive impairment leads to brain vulnerability and reduced reserve, which increases the likelihood of delirium from a mild participant, e.g. change in medication and so on. So all I want you to know in this page is this sentence, which is highlighted. There it is. The delirium is a risk factor for future dementia. So not to be ignored and must be treated based on the Charter of Rights of the patients. It must take its rights in treatment so that it will not get worse and it will not turn into or be a reason for getting dementia. This is for, the delirium. This is for the delirium. So it couldn't be a reason for the dementia. We have to treat it. We have to take the reasons why. And we talk about how to reduce the delirium because it might be like here, like you see here, delirium is a risk factor for future dementia. It's a future factor for future dementia. Also, here I want you to know that delirium increases dementia risk by unknown mechanism. So it is like a oxiding factor. It's like an oxiding factor. It's one of the main reasons. I'm talking about the delirium. It's one of the main reasons that might cause, leads into the dementia. So you have to be aware of this also. The delirium increase dementia risk. It increase the dementia risk. So the risk means the probability that the dementia happened depend on the delirium. So delirium might cause dementia. Don't forget this as well. Those who experience delirium have increased brain atrophy. This is another thing about the clinical pathologic correlates show the patient with dementia after delirium don't exhibit a typical pathology of Alzheimer's disease or lower body dementia, suggesting a separate pathway of neuroinflammation. Anyhow, just I want you to know that the delirium increase the dementia risk of unknown mechanism. They don't know till the moment why. Type, how to distinguish between delirium and dementia? How we can make a distinction between them? Since dementia and delirium both feature disorientation, short-term memory loss, hallucination, both of them are having this, the delirium and the dementia have both features. Disorientation is one. They are common in this. Both are similar in this. Short-term memory loss, hallucination, delusions, and agitation, restlessness. It's important to learn how to distinguish between the two diseases. It's very important. When you see a case, you know that this is dementia, or when you see a case, you say this is delirium. We will talk also about the Alzheimer's disease. and the Lewy body disease, and I gave them parts in this course, and we will talk about them in details on the next parts. What I want you to know that even though delirium can be reversible, can be treated, but it can lead, if it is left, or in some cases, it is a main reason for the dementia in the future. Shall go now, right now, for the part or the question of the part of this part which we are working on, and we'll stop here a few minutes to know the main question of today's part. What are the 3D of dementia, and compare between. Copy, and I will go now here to where I will put my question here at the end of this part. Remember that disorientation is depression is a part of disorientation as well. So I will say here on this slide here, I will put new slide, and I will say here we need to know, discuss the 3DS of dementia, compare between them, compare between them. Like we said before, we have the dementia, we have depression, and we have delirium. And so you have to compare between the three as well. This question, we will stay here for a few minutes to get the answer of this question before we move into our next part in this curriculum. We will move forwards after a few minutes for a new part here. So I will wait here now for you to get your answers about these questions, about this question, about the difference, the 3DS of dementia, and compare between them. Here is our question, and that's what we need the answer for. Thanks, my dears.